Ladies and gentlemen, Mr. Chairman, I want to get back. Takao gave a fantastic lecture, going through the details and showing as nowadays we can reach also preventing surgery in this field. But please come back to the everyday problem you have to tackle whenever a patient comes to you because have a strange hole within the pancreas. First of all, when we talk about cystic lesion, IPMN, we have to keep in mind that there are different degrees of aggressivity in terms of biology. Certainly, we are all aware that the main duct problem is biologically different from the mixed type and particularly from the branch duct type. I would like to focus with the branch duct because this is the real problem we have in choosing the pathway to follow for each single patient we see. And this is the real problem because the biological behavior of the main duct of the mixed duct is a dangerous biological behavior, and we are allowed in this particular field to push for surgery. If we do it, we are not to make a wrong choice. Maybe that we do a wrong choice if we push the patient to surgery whenever we had a branch duct, because the risk of true cancer is very low. And we know that the risk of pancreatic surgery is not so very low, neither in general nor in high volume center. So the disease is a disease with different biological approach. We don't know the time the disease needs to become from benign to malignant, and most of the patients have no symptom. And if we look to the treatment, as stressed, we have to tackle with very high risk surgery and very high and sure risk of impairment and failure in terms of exocrine and endocrine function in the pancreas. So, what to do? And should I resect when, what kind, and can we stop the resection? Takao has already faced this problem. And when I should follow them, is the follow-up safe of the resection? What's the best method we have to use? It's too expensive to follow up. Well, when answering to the question, we have to keep in mind this point. And particularly the neural nodule that at the end of the day seems to be the most important factor, the likelihood of progression in the branch duct, but certainly also the dilation of the duct and the volume of the cyst. But particularly neural nodules seems to me to be stressed in everyday practice because they mean high risk of malignancy and whenever they are present, surgery is warranted. But keep attention that not everything that looks like a nodule is a true nodule. It may be a plaque or mucin, and then coming back to the presentation before, I think that this is everywhere in the world, independently of different choice in the United States or Europe or in the other countries in the oriental part of the world. This is the right and important indication for end-use contrast medium and fine needle aspiration, of course, if you have a target. What happens in the literature? This is, I think, the important message for me today and to discuss together, is the impressive number of guidelines we have in this field. Sometimes I think that we have more guidelines than patients. It's not true, of course. But we have a lot of guidelines that has been changing during the last years, reviewed, etc. So what I would like to concentrate this morning, discussing with you about this problem, is this very last period in which we move from the Foucault to Italian to the international, from the European, the American gastroenterological, and the review of the European. First of all, don't forget that here we are. Expert opinion. Expert opinion is far from the scientific demonstration. The room is so big, and should we be in a small room drinking a coffee together, probably I would tell you that it's not always ready and true that people that goes to guideline discussion is an expert. Because many doctors around the world have to stay home because they have a lot of patients and they have no time to go to discuss around the world. So please, be careful when you read guidelines coming from experts in brackets. They are very heterogeneous, with low level of evidence, low clinical applicability in several cases. Let's go to the international, just to see the main factor dealing with surgery yes or surgery no. Jaundice. Of course, we are drinking coffee. Whenever you have a jaundice patient, because some periampullary problem, 90%, 99%, the Whipple is the best biopsy you can do in the real practice. Sometimes you have some Whipple for nothing, but a very small amount of cases. And of course, it should be better if this risk for nothing Whipple is carried out in a high volume center. Because, you know, luck is blind, but the unlucky is twice blind. And whenever you do something for nothing, you have a lot of complication. Yeah? Okay, that's the real life. So, jaundice is a good indicator for thinking about surgery. Enhancing mural nodus, certainly. Now start the festival of the millimeters. in the guidelines, we have the festival of the milliliters. 5, no, 6, no, 7, no, more than 7, but not more, less than 15. Be careful. Main pancreatic duct, more than 10. Follow up after 3-6 months, setting the limit according to the diameter of the cyst. European surgery, if symptoms, of course, but you have to demonstrate the symptoms are pancreas related, size more than 4 centimeters, mural nodules, diameter more than 6, none or 5, enhanced, dilation of the main pancreatic duct and elevated CA 19.9. Follow up, if the size is less than 4 centimeters without a risk factor, asymptomatic patients. Well, if we move to the systematic review and meta-analysis of the patients that are in the follow-up, and we did together with our friends of the San Raffaele Hospital in Milan and with the Massachusetts General Hospital, looking to 20 studies and this number of patients. The overall mortality rate was 0.9 with an annual risk of 0.2%. So we have once again to think about the balance in between the disease and the treatment we can offer. And then considering the rate of malignancy and the mortality-related rate, surgery in terms of prophylactic surgery represents an over-treatment in this group of patients. Surveillance for low risk without worrisome feature of high risk stigmata seems to be safe. And this is also demonstrated looking at our own experience, who can benefit for a follow-up, the branched up without worrisome and without high risk stigmata. Keep in mind enhancing mural nodules and the increased serum level CA19-9 are the most important, seems to be the most important factor to be reminded for surgery, yes, and surgery, no. I don't think that's important to show you our behavior in the Verona Pancreas Institution, but whenever we have a no to this question, symptoms, neural modules present, dilation, CA19-9, grow more than 2 millimeters per year, etc., we have to consider surgery. Consider, not do, consider surgery. And of course, whenever we have no, we start our follow-up as stressed in the literature, and this is the whole experience watching to more than 3,300 patients, and you see that during the year, the volume of the cyst reduce and the number of observation increase. We are going to do an earlier diagnosis nowadays, and you see that the number of patients that have been operated on upfront after the first observation impressively increased the number of patients that now are in the follow-up, and the red area is the crossover patients that move from the observation, the follow-up, to surgery, and you see that the number of patients that are crossing from the gray area to the blue one is going down during our experience. So, I think that at the end of the day, these are the data we have. The risk in our follow-up and in our observation surveillance policy is 0.6 mortality, because of course we have some patients, we are not perfect. We have some patients who develop cancer in the follow-up, and we were not able to treat in a radical way. But if we look to our mortality in pancreatic surgery, that is around 2%, ranging from 1 to 3, depending on the different year, but is around 2%, we are still in a different balance. So, conclusion. The right choice tool doesn't exist, and the zero risk doesn't exist. To approach in a conservative way the side branch IPMN is not an hazardous. The hazardous of the surveillance seems to be lower than the hazardous of surgery nowadays, at least in the vast majority of the patient. And the final message, very important, I think that we have to share the decision with the patient, because patients are aware, must be aware, about the partial knowledges we have of this particular topic. So I think the time is up to start at the beginning of the Meet the Professor session with question, drinking a coffee also outside. Thank you.